Arun, have you joined?
Yes,
Mr.
madam. Yes.
Arun? Yeah, please start with the prayer song and the lightning
Just
of the,
1 minute.
as this is our first webinar.
No, always any webinar starts with the prayer.
Yes, sir, yes.
Okay.
Yes, yes. Okay, sir.
Yes.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Arun. With this prayer, I will be happy to start my tenure with this webinar series. Thank you, Asrana sir. Actually, this is this kind of series till now nobody has made. So I wanted to start from the basics, and till tenure gets over, I will like to go into the advanced cases and discussion about the disease and all. As we know that this is a laparoscopy or endoscopy is a total technological based thing. So we should know the techniques and technology and the equipments what we use in thoroughly, so that we will run our surgery smoothly and without any hurdles. So this is, as you know, I given in flyer also, this is our series of evening with endoscopy expert, and this will be every Wednesday, every month, third Wednesday, 5 to 6:30 p.m. we'll conduct this webinar. And as for the clinical touch and to give importance to the postgraduates also and the beginners also, I included one case presentation also in this webinar. First two talks will be there, and last one will be the case presentation by the junior consultants and by the postgraduates who are doing interested in endoscopy. So thank you, sir. And I tell my Dr. Priscilla, a dear one, to proceed further.
Thank you, Prabha Madam, for briefing the event. Dr. Shobha Madam is not able to join right now. Probably she'll join a little later. Let me, on her behalf, extend a warm welcome to all the participants who've joined for our first webinar. I would like to begin by welcoming our President, Dr. Durgadas Sir, Kasoga President, for giving Endoscopy Committee this opportunity to conduct a series of academic events. Thank you for your support and guidance, sir. We hope that in this academic year, under your leadership, we will be able to reach and inspire a lot of budding endoscopic surgeons. We welcome you to the session. I would also like to welcome the office bearers of Kasoga, Dr. Bharti, the past president, Dr. Shobha, Secretary General, Dr. Rajashri Ma'am, the President-elect, and Dr. Shobha Bembalgi, the Honorary Treasurer, Dr. Ashalata Madam, the Executive Member of Northwest Zone. I would also like to extend a warm welcome to our speakers for having accepted our invitation. Dr. Nitin Shah, who will be joining us shortly, Dr. Rishabh and Dr. Vaibhav, who have joined us. Thank you, sir, for accepting our invitation, and thank you for accepting to share your academic thoughts with us. And the end, I would like to welcome all our participants for joining us on our first webinar sessions. And let me highlight, as Prabha Madam said, for those younger endoscopic surgeons and the postgraduates, this is a very good opportunity for you that if you make up your attendance of 80%, you would get a hands-on training for 3 months at free of cost. So, welcome you all to the first webinar session hosted by the Endoscopy Committee of Kasoga. Moving forward, I now request our Kasoga President, Dr. Durgadas Sir, to please give his presidential address.
Good evening, everybody. At the outset, I really congratulate Dr. Prabha Desai. This was my dream that actually Prabha was not very much keen on getting into these things. I told her, people like you should get into the folds of Kasoga so that the whole state will be benefited. For the sake of the people, for the sake of the practitioners, she has taken this effort. I really thank you and congratulate you for this effort you are taking. And this is one of the beautiful way of presenting the webinar series. Arun, mute madappa.
Yes, sir.
Mute madappa. Arun, mute madappa.
Yes, sir, please go ahead.
Yeah. And this is a beautiful way of taking the subject. Prabha is such a academician, I can say, even a good teacher. See, this is how the thing should be presented to the students or the junior practitioners, and even for the seniors to fine tune their own knowledge. This is required. This is the basic because, as Prabha told just now, it is technology based field. So everything we should know about the instruments, maintenance of the instruments, how to operate the things. If something goes wrong in between the surgery, how you should know how to rectify the things. So, Prabha, once again, I thank you so much for your involvement and your whole team, like Priscilla, the whole team. I really congratulate you. I thank the three speakers of today evening, Dr. Nitin, Dr. Vaibhav, and Dr. Rishabh, for accepting our invitation and coming here. We are all eager to listen to you. I acknowledge the presence of our President-elect, Dr. Rajashri Palladi. Without wasting much time, I will say good luck to Prabha. Please go ahead.
Thank you. Dr.
Thank you, sir.
Nitin has joined just
Hi,
now.
Prabha.
Welcome, Dr. Nitin Shah. Yeah. Hello.
Hello. Prabha, I need to start one surgery. Can I
Okay.
finish in my talk
Okay.
before?
No problem. We will just
So can I start my
Priscilla.
talk? Because if I start surgery, then I may join back at 6. So
Yes.
with your permission and Mr. Rishabh Vadera,
No, please.
yeah?
Uh,
So I can just start
yeah.
with my presentation so that you all can continue after this because patient
Yes,
is
sir. Just
getting
give us
induced.
a
So
minute, sir.
meanwhile, I'll just finish my talk. Yeah.
Yes. Yeah. As Dr. Nitin sir said, he has to join back for a surgery. Let us begin with his session. Review such application of 3D and 3D camera technologies. And Dr. Nitin Shah is a recipient of Gold Hand Awards, a recipient of Wonder Foxian Award. He holds a world record holder for removing the heaviest fibroid and the largest para-ovarian cyst. He's into his 18 years of practice. He's the president-elect of AFG. He's done more than 65,000 of laparoscopic surgeries and many publications to his credit. We welcome you, sir, and thank you for joining us and accepting our invitation.
Thanks a
Over
lot
to
for
you,
this
Nitin, sir.
opportunity. Thanks a lot. Yeah, thanks a lot for this opportunity. And sorry to just ask for the early slot because of the emergencies. Today, my talk on about 2D, 3D laparoscopy. Okay, so this is my journey from resident to president of AFG. Okay, just adding P in front of resident. But I started my private practice in 2006, almost nearing 2 decades now. So when I started my practice, I was totally confused what to do, whether to start sonography, IVF, obstetric, and finally I ended up doing an endoscopy. So this is how we started our freelancing journey. My anesthetist friend took me out as a freelancer who told me you are doing better job than other. And this is how we started with Telecam DX2. How many of you have seen this camera, single chip camera, which is the standard definition?
That we used to
Okay.
bring in
So
KM.
we have started with 14-inch Sony TV, Telecam DX2. And this is our journey started way back in 2007. All fit in this car. And we problem. Hello.
Hello. Yeah.
Yeah, am I audible?
Hello. Yeah. I think your side internet problem is there.
Yeah, okay. So poor vision is the problem. So when we attended in 2007, we went to Kiel. There was a talk on this Image One Hub, which was HD, which they were going to launch. Okay, and we attended that. When we asked the cost was nearing 18 lakhs. And so we thought, who will buy this? And this was our first reaction. Pagal hai kya? Kaun buy karega itna महंगा? And then we went to Black Cuckoo Forest visit. We stopped that lecture in between. But life had a different plan. And within 3 years, we bought the entire set, which is Image One Hub, LED, and everything. So from there, it was no looking back. Bought Gen 4 harmonic, then Gen 11 harmonic, then Carl Strauss oscillator, and big cars. And then this is the advancement to the 3D, which adds luxury to life. So definitely, this is how we move in our car, stacking all the equipment and everything. Okay, so what is the difference between 4 standard definition, 4K and 3D? HD basically entitled a resolution that is higher than a standard. HD generally refers to image with a 720 horizontal line or more. So 720p horizontal line refers to HD ready. This was the past camera. Now they no more exist. And nowadays what is available is a full HD, 1080 by 1920, which is full HD. And now we have a 4K system, which is 3840 by 2146, which is 4 times HD. So this is how there is an evolution of the camera system in the market. So we started our journey right from standard definition, which is 720, less than 720. It was 560 lines, then to 720, then HD, and now 4K and 3D. So your HD means 2D, which has no depth perception. So what are the surgical application for 2D camera technology? Laparoscopic visualization, minimal invasive surgery using 2D cameras for visualization, endoscopic like ENT, the general GI surgeries, general surgeries, gynecology and urology. There is a wide application of the 2D camera system, including orthopedic where arthroscopies and shoulder joint, they use 2D camera system for visualization. The only disadvantage is limited depth perception and require expertise to accurate interpretation. 2D is cost effective, generally less expensive than 3D system, and it's widely available. The 2D systems are now you can find in every corner of the country. So, and there are many surgeons who are trained with 2D system. 3D enhances the depth perception, improve precision, and reduce complication. So what is 3D technology? When watching video in 3D format, the picture seems to jump outside the screen, giving it a real-life experience. It gives the illusion of depth to the video. The 3D experience is achieved through a technical called stereography. Let me explain this. It's based on how a human eye receives the input, the way the human brain processes. The pupil of a human eye are about 6.5 centimeter apart. Therefore, each view is seen from a different angle and generate a unique image. The brain then creates a single image by merging the image together. The slight difference between the image from the right eye and the left image from the left eye allows the brain to judge the depth. This creates the 3D illusion. And it's the depth. So there are 3 different types of 3D technology. One is anaglyphic technology, which was used way back in the movie called Chota Chetan, where the glasses have red and blue color filters. Then came the polarized technology. Everybody has seen Avatar movie. So that was the polarized technology, and now active technology, which is shutter technology. So all these days we have been operating with the one eye closed in a HD, because if you close one eye, you can see there is a loss of depth perception. Everyone can keep the finger in front of your eye, close one eye, and you can see the depth is lost. So this is what we are doing in open surgery is the 3D, natural 3D. But are we operating with one eye closed? No. So with the 2D camera, we always operate with the one eye closed. That is how it looks like. So it's like everybody knows this single eye and one eye. Okay, so we have to decide whether we want to operate with one eye or two eye. And hence, you should be wise to choose your camera system. So 3D is like actually sitting inside the abdomen and operating. All stalwarts ask for the 3D even in conferences because of the depth perception and high-end surgery can be performed. So 3D advantage of 3D camera system is improved depth perception, enhanced surgical precision and accuracy, better visualization, and reduce errors. And in my experience with the use of 3D camera system, the operative time reduces by almost 30 to 40% because the depth and the clarity is so much. You can all the planes and you can operate a little bit faster. The application of 3D camera system is robotic surgery, laparoscopic surgery, and neurosurgery. Specific application, definitely urology. You have a radical prostatectomy. The 3D camera system is must for the 3D prostatectomy and nephrectomy. Gynecology, definitely hysterectomy and severe cases of endometriosis. 3D can boost your surgical skill and cardiothoracic surgery. The future direction, advancement in image processing integrated with AI and increased adoption, growing use of 3D camera system in various surgical procedure. And the future development includes augmented reality integration, the combination of 3D camera system with AR for enhanced visualization, then artificial intelligence assistant, AI-powered image analysis and decision support, miniaturization, that is smaller and more compact 3D system, the VR and AR potentially application in surgical training and planning, and finally the Google glasses. This may be the future. So coming to the virtual reality and augmented reality, virtual reality and augmented reality are immersive technology transforming interaction with digital environment. The VR creates a fully virtual interactive world often experienced through headset. AR overlays the digital element into the real world via a device like smartphone or a glasses. Both technology revolutionize the field of such a gaming, education, healthcare, and training. So VR helps in surgical planning and helps surgeon to visualize complex anatomy and training. VR simulates surgical procedure for practice. So this is the video of the training using VR. The case of the orthopedic.
Is a bit weird. The fusing of medicine and video games with faceless surgeons, their hands floating around a virtual patient.
And I'm gonna line those up with the femur.
Orthopedic surgeon Danny Goyle is the medical mind behind the made in Canada invention called Precision OS.
I think the middle sign is probably the correct one.
The virtual reality program is exploding in popularity. Dr. Megan Shields is a third-year surgical resident and is still new to practicing using Precision OS, along with students from 22 other medical schools across North America.
So this is how the use of virtual VR can be used for training of the student. And the actual application is that this is the MRI pictures which are fed to the system. And then they produce a 3D model and they give you the exact location where the adenomyoma or fibroid is. And that helps in the localization intra also. So this is a system, you just feed the VR and you can see that it marks the area which has to be removed. This is another picture of the 3D model and you can see where the adenomyoma is. And during surgery, one can locate where exact the incision has to be made and what part has to be excised. So these are all this incoming thing. One has to keep abreast of the technology which is coming in to find out what is next. AR is an intraoperative guidance. It overlays the digital information into the patient's anatomy, enhance visualization, the real-time data during the surgery. So this is the raw video of the lab call. And now you can see it will just add on to the AR in that. So now this is augmented video, which says the tracking of the gallbladder. So it will isolate the gallbladder for you and it will help in the dissection, where to incise, where to cauterize, what part to remove. So this is it is a hands-free documentation. Surgeon can record and annotate procedure, real-time consultation, remote export can provide guidance.
Health Alert testing Google's latest technology in the operating room. As Nasita Kwan shows us, a Chicago surgeon is among the first in the nation to test Google Glass, the wearable computer that allows you to record video and access the internet, all while performing surgery on the patient. In October, this 31-year-old patient fell and badly fixed that with a surgery that will be one of the first in the nation to take Google Glass into the world of medicine. Simply put on the device, look upwards, and your internet-connected, voice-activated glasses display any information, recipe to directions.
Did I take enough off?
In the operating room, the doctor never has to look away and refer to pictures or scans that guide the surgery.
When you want something, you just look up in your right-hand corner and you can see something. And then when you don't need it, you're ready to go back into your surgery.
And with a flick of the finger or a voice, he can call up other medical information he might need.
So challenges are the cost, accessibility, high cost, and limited availability. Technical issues, still there can be technical glitches in all these gadgets. Benefit, definitely improve patient outcome, enhance surgical precision, and reduce recovery time. Comparison, the learning curve, 3D system may require additional training. Cost is definitely more high, but definitely give you the better depth perception. Literature says that 3D technology provides surgeon and additional information on the spatial depth and improve the vivid depiction of the anatomy. Publication which says the advantage of. So my friends, invest in this land, big car, product of prestige. So I say just invest in the right equipment so that your surgical outcome is better. The change is only constant. I request everyone to change their mindset and accept technology. The technology advancement is necessary, the progress and beneficial to society. Make technology cheaper. Don't replace the cheap with cheaper option. As we change from bullock cart, train, flight, and now bullet train, the same from the pager, Nokia phone to iPhone and then fold phone. So we have to change ourselves and adapt to the new technology. I think everyone should debate how we can make 3D technology cheaper rather than comparing it with HD, and we can have a better choice. Every surgeon, open or an endoscopy, has its own share of complication. The greatest hazard to the patient is not the surgery, but the surgeon. The choice is yours. And as experience increases, the exclusion criteria relaxes considerably, and one can proceed for more complicated cases using the 3D. Again, the choice is yours, whether 3D or an HD. Many times the life is like this picture. We have the resources, but we make the poor decision. So let's believe in chasing the excellence every day, and choice is definitely yours. 3D increases your operative lifespan and delays retirement. So again, choice is yours. Be not be afraid of growing slow. Be afraid of standstill. What mind doesn't know, I cannot see, but laparoscope can see everything in depth. So thank you very much for this opportunity.
Thank you, Nitin sir, for your wonderful talk. Do we have any questions from the participants? Sir, I have a question. What is your experience of AR in tracing the ureters during endometriotic surgeries or hysterectomies?
I have done only in the robotic module and not on the live surgery. AR and this is still yet to come in India in widespread, but I've definitely used that in the module during the robotic surgery. Otherwise, we are using 3D pre-COVID era now. Almost 5-6 years we are using 3D at our center, and it has definitely add on to the surgical skill, the anatomy, dissection, everything becomes very, very easy. So definitely one should look upon with the 3D system now. And if not, at least HD.
Hello,
So
Dr.
thank
Thank
you
you,
and
sir, for
sorry to
motivating
rush.
us.
Yeah, good evening, sir. This is a very nice presentation.
Thank you, sir.
So regarding the use of energy source and AI, is there any advantages that is done with respect to the energy source and AI right now?
Yes, definitely. AI will help you in selecting the right pedal, and if you are doing some wrong or over your this pedal or something, it will definitely guide you.
Yeah. In that particular, my question is:
There's
suppose
a lot
if we are
of
very
things going
close
in
to
the
the
AI.
if we are very close to the ureter, or if our bipolar or the vessel sealer is on the ureter, is there any mechanism that avoids the delivery of the power supply in that case? Like
Oh,
depending upon the impedance of the tissue.
No, nothing like that. But it will definitely highlight that you are in the wrong plane. Whenever you learn on the simulator will vibrate and tell you are cutting wrong thing. But maybe in live surgery, it will, if sometime may give you alert, but you may not be able to stop your action. So, but if you see better, you will not you will not cut the ureter. That is the whole advantage of the good vision.
No,
Okay.
apart from seeing, sometimes it is very difficult, especially in deep seated endometriosis and all. If there is a mechanism which identifies this one, probably it is still a better innovation, I feel. That's why. Especially very close to rectal mucosa identification, mainly with the impedance of the instrument. Tissue, yeah.
Yeah.
Okay, sir. Okay. Thank you very much, sir.
Thank you. Thank you, Dr. Nitin, for giving your valuable time in between the surgeries. And I feel we should proceed for the next. Anybody has a questions? Dr. Priscilla?
Yeah, ma'am, there are no more questions in the chat box. Let's proceed with our second talk by Mr. Rishabh Vadera. The topic is from lens to screen.
Priscilla, there are
Yes, ma'am.
chairpersons also joined or not?
ರವಿಕಾಂತ್ ಗೌಡ್ರು ಬಂದಿದ್ದಾರೆ, ಅಕ್ನಾಲೇಜ್ ಮಾಡಿ ಅವರು.
ಬಂದಿದ್ದಾರೆ. Okay.
ನಮಸ್ತೆ ಸರ್.
Yeah.
We are very happy to have you.
Thank you, sir. Thank you so much, sir.
One of the best chairperson who has done wonderful job during the last committee works. Wonderful.
It was all because of your cooperation, sir. Thank you so much, sir.
Just acknowledge.
Now Prabha is also doing very well. Enthusiastically created all the team.
See, Ravikant sir, it is all your training only. So we will not take the time of webinar. We will proceed.
We welcome you, Ravikant sir, to our first webinar.
Thank you.
Yeah.
Madam B. Ramesh sir has not yet joined.
Okay. No problem. You just introduce that she was a chairperson and go ahead with the next talk.
Yeah, Dr. B. Ramesh sir is the chairperson for our second session, wherein Mr. Rishabh Vadera would be presenting us for his topic. He's a experienced marketing professional with a strong background in developing and executing the strategic campaigns to drive product adoption and market growth. We welcome you, Mr. Rishabh. Over to you.
Thank you. Thank you so much. I'll just share my screen. I hope the screen is visible.
Yeah.
Yes.
Okay. A very good evening to all the doctors, delegates, and respective faculty members. Special thank you to Dr. Durgadas Asrana, Dr. Prabha Desai, and all the Kasoga members for giving Karlsruhe the opportunity to present at the Kasoga Endoscopy Committee webinar. On the topic of Know Your Camera System, I am Rishabh Vadera, working as product specialist at Karlsruhe since 2021. Today, we are here to discuss the topic from lens to screen, the science behind endoscopic visualization. So what is an endoscope? Endoscope is an instrument which is used to look inside the body. What leads to the invention of endoscope? A large cut opening, longer surgical time, more blood loss, longer exposure to anesthesia, more infection possibilities, and longer post-op recovery. Hence, the laparoscopy came into the picture. The benefit it provides to the patient were smaller incision, reduced post-op pain, reduced blood loss, and quicker recovery. What benefits it give to the surgical team? Improved patient care, procedures can be quicker, and better visualization. So no technique in modern times has become so popular as rapidly as laparoscopy surgery. Let's start with some history of optics. Dr. George Bursey was Hungarian-American surgeon and a pioneer in minimal invasive surgeries. He developed instruments for laparoscopy surgery that have been incorporated into minimally invasive surgery techniques used today, whereas Dr. Harold Hopkins was a genius physicist. His experiment with magnification and optical clarity led Dr. Bursey to visit Dr. Hopkins in the UK, an authority on optics who had invented the rod lens. This came to the attention of Dr. Bursey, who immediately saw the value and its application in endoscopy. He explained the application of Hopkins' discovery and arranged a meeting with another well-known acquaintance who had just started a medical device company. That other acquaintance was Karl Storz. So this is how the Hopkins telescope were invented. So let's start with what the endoscope is made up of. The conventional glass lens system, which uses a series of objective lenses to transport the image down the laparoscope, whereas the Hopkins lens system containing a series of quad rod lenses that carry the image through the length of the scope to the eyepiece. Rigid Hopkins rod lens system provides good resolution and better depth perception. The Hopkins lens system uses more glass than air, so it has improved light transmission. Here's some more information on lens. So here, this is the conventional on the first image. This is a conventional glass lens image. Here you can see blue color is the lenses, whereas gray color is the air gap. This is a conventional, whereas this is a Hopkins rod lens, where the air has been replaced with the large rod lenses, and whereas the glasses in conventional endoscope has been replaced by the air gaps. So you can see here different parts of a telescope: the rod lens, the spacer, the eyepiece, and the light source connector. So this is how an endoscope is made. So what is rod lens? A special cylinder lens which is highly polished on the circumference and ground on the both ends. Rod lens helps in more light transmission and provides good resolution. Now let's talk about different type of lens design. First, let's look at the lens design that is now a spherical lens. On the right side, you can see the spherical lens. This is what allows the image to have more illumination and edge-to-edge clarity. Traditionally, laparoscopes are designed with spherical lenses, which is on the left side, which are easier and cheaper to make. However, they exhibit spherical aberrations, which cause field curvature, making the edges appear unsharp. Here you can see the unsharp edges. So by definition, the outer part of the lens do not bring light rays. Do not bring light rays into the same focus as the central part. Here you can see the light rays coming, but not on the central part. It's distributing. So as you can see demonstrated in the image on the left, an easier way to explain it, the lens is more curved and the light does not come to the common focus. So the image cannot achieve uniform sharpness. When you shift to an aspherical lens design that straightens out the curved image to a flat image, reducing or eliminating the spherical aberrations. The result is what we now see with the Rubina laparoscopes or any Herald's telescope, a high resolution sharp image from the center to the edge. So now comes to field and angle of view. What is field of view? The total area visible at any given time through an endoscope is a field of view. Whereas the angle of view is the angle at which the endoscope can visualize the area. So angle of view is the tip of the telescope, and field of view is the how much width the field it provides. Then comes different type of telescopes in the field of endoscopy. There are four basic group of endoscopes: rigid, semi-rigid, flexible video, and flexible fiber optic scopes. So our goal is for you to come away with the following three things: how it's made, where it's used, and what it's used for, and how to identify the scope. No matter what type of scope it is, the endoscope is arguably the most critical link in the imaging chain. Let's focus on the optical endoscope for a minute. These are available in different sizes with different angle of view. So this is the most interesting part. Different angle of telescope signifies different color of the telescope as well. So here you can see the color codes. 0 degree, if it is green in color on the tip on the light cable adapter, then it's 0. If red, 30, yellow, 70, black can be 12 degree or 45 degree as well. So now comes to light guide cable. For light guide cables, use compatible light cable with different diameter of the telescope. Without a suitable light cable, you will either have too much light or too much heat on the camera head. So therefore, you need the perfect matched light cable. So here are some troubleshooting notes on the light source. If you wish, you can take a snapshot of it because I have less time, so I'll quickly move on forward. And here are some care and maintenance tips. Carry with care usage of basin during cleaning, periodic cleaning of light guide port, autoclave in telescope tray, if you wish to.
Sorry, Rishabh, you just
Yeah.
highlight on these things, no? No problem.
Okay, okay, ma'am.
Because this is important thing for practically.
Yeah, yes, ma'am.
Okay.
So care and maintenance. So the telescope or any lens or any telescope, any camera head, the light cables should be, after the surgery should be kept in a separate tray or separate uh, in a separate where there is no hurdle. Because if let's say if you keep a trocar and a telescope together in the same tray, it might harm the telescope. The rod lens can be broken. The sharp edges of trocar can disturb the screen of the lens, or it might produce scratches on the telescope as well. So it's always necessary and useful to keep both separate, the pointed instruments on the separate tray and the telescope camera head light cable in a separate tray. So now that we have covered the type of endoscope, we can circle back to our traditional imaging chain again and move on the next link. The camera represents a transition from optical to video. The camera is digitally acquiring the image that the optic provides and sending it on its journey through the video portion of the imaging chain. We refer to this as image acquisition before we are acquiring an image from the optic. Cameras have evolved based on few things: camera chip resolution, SD, HD, 4K, the type of camera chip, CCD versus CMOS, imaging capabilities, fluorescence, 3D, functionality in surgery, dictates where the cable comes out of the camera, and sterilization methods. So future of imaging, there are two types of chips available in the endoscopy camera head, which is CCD, which is charged coupled device, and CMOS, complementary metal oxide semiconductor. There is a lot of buzz in the market that which is better, single chip or three chip, CCD or CMOS. But what exactly is the underlying need? The underlying need is to get high resolution, high quality images. Historically, CCD chips have been far superior to the CMOS chip in the market, and CMOS was deemed the low cost, low quality alternative. However, it had two very important features crucial to the consumer market, especially smartphone photography, low energy consumption, and low prices. Due to these factors, CMOS became the technology of choice for the consumer market, and enormous spending in R&D occurred, improving the one inferior CMOS chip in a way that they surpassed CCD in terms of resolution. Here you can see four type of resolution: SD, HD, Full HD, and 4K Ultra HD. So now what is color temperature? Color temperature is very much useful while choosing the which light source which should we have in our OT. So color impression of a light source. Here you can see the graph on the right, on the bottom right side. It is measuring the temperature of the lamp of the light source. Each light source has a different color temperature. It is measured in Kelvin. As higher the color temperature, as colder seems the color impression and the way around. So let's say here we have seen LED or xenon. It has higher color temperature. So it starts with equivalent or above 6000 Kelvin. Whereas halogen, which we earlier used to have, had lower color temperature, which used to give yellowish bomb light. Okay, here comes the myth buster. We usually ask that what is the wattage or how much wattage of the light source is. But the major question we should ask is that how much is the lumen of the light source? Because lumen only justifies the working nature of the light source. This is the earlier version of HD camera system, which Dr. Nitin has also shown to us, which I just wanted to show you for the reference. In this, we could have connected all type of scopes plus USB as well to record images and videos. It has been discontinued now. So now comes Image1S platform. This is the most advanced generation of camera system, which provides expandability so that you can expand or upgrade to newer technologies like 3D, ICG, or even exoscopy. Exoscopy is to record and to visualize any open procedure on the main monitor. This is how the dashboard of the camera system looks like with intelligent icons. So why do we say it as intelligent icons? Because it shows that how much percentage of pen drive has been filled, or that what link is connected to the system, or whether the PIP mode in display is enabled or not. These are different image enhancement modes. You can see the different color differentiation in picture-in-picture mode, where one side is the white light image and the other side is the spectral color shift mode. So the Image1S system also provides the option of two camera heads to be connected to the same endovision system. For example, if you are doing a hybrid surgery, so one side you are doing a hysteroscopy and the other camera head you are doing a laparoscopy. So on the same lap tower, you will be able to appreciate and visualize both the visions simultaneously in PIP mode or side-by-side image. Our next topic is 3D endoscopy visualization system. So what is 3D and how it works? So as sir had also shown in his slides, so human have two eyes positioned side by side, allowing each to see the same area from slightly different angles. The brain combines these views to create a single three-dimensional image with depth, height, and width. Similarly, 3D video endoscope also has two eyes on the tip, and it gives a stereoscopic image, allowing to see the same area from slightly different angles to create a single three-dimensional image. And it is available in through two varieties, 0 degree 10 mm 3D or 30 degree 10 mm 3D. So what are the benefits of 3D? Short learning curve, excellent depth perception, and one can visualize the 3D anatomy of organs within the body. Now let's come to 4K platform, which can be plain 4K or 4K with ICG as well. So what is 4K? 4K is 4 times the resolution of a full HD image. That means, as we know, the resolution of full HD is 1920 into 1080p. So the resolution of 4K is 3840 to 2160p. Now I'll show you the why 4K is much better because its color gamut is BT 2020, whereas HD's color gamut is BT 709. What is color gamut? Color gamut is defined as the range of colors which is particular device can produce or record. It is usually shown by an enclosed area of the primary colors on the device on the chromaticity diagram. For example, the primary colors of monitor are red, green, and blue. Hence, the color gamut of the monitor is shown in a triangular area. Here you can see color. So as I said, color triangular area enclosed by color coordinates of the monitor, red, blue, and green color. Here you can see the difference between two images. The upper one is of HD, whereas the lower one is of 4K. So our first impression was that the 4K image appears brighter and more illuminated than the HD. In particular, dark areas and deep structures are better visualized. By taking a closer look at the colors, the endoscopic image of H3Z or HD on the top left side seems to be a bit grayish in comparison to 4K, and the 4K system looks more vital and the colors are richer and saturated. As I said before, structures, especially superficial structures, are better visible. Structures such as vessels are concisely illustrated. Furthermore, details are easier to identify or are better visible in the 4K image. So this is the 4K imaging chain. You don't need any special 4K telescope for the imaging, as the chips are in the camera head and not in the telescope. As earlier I had shown you the diagram or the anatomy of the telescope, there was no chip. So telescope just have rod lens inside them. And then this is the 4K camera head on the top right side. Then 4K camera control unit and 4K monitor. So the most advanced camera system in the market, which has all the features 3D, 4K, ICG in a single camera platform. 3D video endoscope is also available in 4K with ICG. This is the only camera head in the market with two full 4K sensors. One is fully dedicated to white light and the other one is dedicated to ICG. So here you can see the difference between two camera heads. One is single chip and the other one is dual chip. So when the ICG mode is on and it's in overlay mode, overlay means white light overlays the ICG. So here on the downside, you can see single chip camera, which has a 30 frames per second. So single chip camera is means doing the work of ICG as well, plus white light image as well. So you can see the increased latency in the downside image plus with lower frame rate, whereas two chip camera has low latency and high frame rate. So LED light source, we were able to harness the power of a NIR ICG or near infrared ICG laser without the hassle of the laser. With two LED light source, we offer a custom optical assembly which is capable of mixing two LEDs, offer up to 30,000 hours of life, no laser safety precaution, and no laser training for staff. So clinically, now I'll switch to ICG, a little bit about ICG. Over the last couple of years, we have spent a lot of time discussing the clinical and financial impact of ICG in biliary and perfusion application, and looking at how ICG can help mitigate the cost of complication by improving clinical outcomes and patient care. ICG is indocyanine green, which is a dye which is used in surgery to enhance visualization of anatomical structures and access tissue perfusion. In gynec surgeries, it is used to improve visualization of certain structures, particularly the ureter and lymph nodes, and to assess tissue perfusion, it can be administered intraoperatively through different routes. There's a fluorescence guided imaging in laparoscopy. So infrared range is 780 nanometer to 1000 nanometer. So ICG excites at 835 nanometer. A very important point to visualize ICG, the telescope, the light source, the camera head, and the light cable should be ICG compatible. If any of the chain member is not working, or let's say if we use any of the chain member that is not ICG compatible, the ICG will not work. Here are different imaging modes of ICG: overlay, monochromatic, and intensity mapping. Here you can see the overlay mode, which means white light overlays ICG and how brightly the ureter is visible. This is another mode, intensity mapping, which represents the relative values, and it is very beneficial for lymphatics. Next is specialty glass that aligns with white light and NIR. This is the reason why you see a sharp image when in overlay mode for both white light, and what eliminates the need to refocus. So if you think about a prism, and look at how glass refracts white and NIR light differently. So, well, the same thing applies in our telescope. The focal point of white light and NIR are split, which can cause one or both images to appear.
Arun?
Yeah.
Hello, Mr. Arun, please unmute everybody, no? Sorry, mute everybody, no?
Yeah, muted, ma'am.
Okay, so the design of Rubina scopes have fixed this by an optimized optical system with specialty glass, perfectly aligns with white light and NIR image. This is how we see the sharp overlay image and do not need to refocus when switching back and forth. So these are some troubleshooting points. So why necessary before starting of any surgery in the primary colors by counterbalancing them precisely. For the camera system, to understand the imbalance, we need to provide a reference point to the camera system against which the camera system will check the balance. Once the camera system gets the reference that it is white, it calculates the imbalance and applies counterbalance to the entire image. So we need a white reference point before the starting of any surgeries. These are some troubleshooting for camera head. If let's say before the start of surgery, you need to check whether camera head is working or not, or there is no image on monitor. So monitor's own switch is on or off. Check if the monitor set to correct input or power cord is inserted or not. Then foggy image. Foggy image is the distal lens of the telescope should be cleaned intermittently with hot water, wiping with gauze before applying anti-fog solution. Ensure and moreover ensure the cannulas of the trocar are clean and there is no tissue in the way which insert in the way while inserting the telescope. And the another point is fumigation of the OT. Camera system components are delicate. Fumigation can cause deposition of the chemicals. Either keep these well covered or take them out of the OT during fumigation. This will enhance the life of the product. So here are some pre-procedure guide. So you can go through the same, and I'll just tell you: have the scrub tech inspect the telescope without touching the eyepiece, wipe any moisture of the endoscope eyepiece and distal tip, wipe any moisture of the card edge connector. Card edge connector is the connector we connect it to the CCU or camera control unit. Explain how to means how to secure the endoscope into the coupler, attach the light cord, white balance, and confirm the image. So troubleshooting guide for when you have a poor image during a case. Remove lens, wipe the telescope tip and the camera head tip. Light source should be on off or standby mode. Increase the setting. CCU reset it, and then monitor should have a presets. Monitor also has some presets. So if we are using a Karl Storz monitor, let's say, then monitor will have presets of Image 1S or Image 1 Hub, earlier model. Then fogging of the telescope. Move cannula to a non-CO2 port. Replace endoscope. Means if 5 mm or smaller endoscope are more susceptible to damage. Then these are 4 P's. Power. Turn on the main switch on the card to confirm all devices are on, including the monitor. These are before the start of surgery we have to check. Picture, plug camera head into CCU, confirm image on the LED or LCD. Pressure, confirm CO2 flow from the insufflator and that the CO2 tank is full. And then paper, if we are using a printer, then we can use P. This new and drastically improved imaging chain brings extraordinary value, but it's critical to remember that our overall Image 1S design philosophy and all of the capabilities associated with it deliver the value of one to our customers. And this is why we want to emphasize not on the technical value that you just reviewed, but also on operational, financial, and clinical value as well. So thank you. So if anybody has any questions for me, please they can ask.
Yeah, thank you, Rishabh. It was a very elaborative talk. Actually, just I want to ask you, see, will you give some this thing, some guidelines about fogging prevention? I think we should use take if you keep the scope long time into the AC room, means into the operation theater just before using, that will also cause a fogging. Do you advise them to keep in a hot water for 15 minutes before using?
Ma'am,
Whether
so
all telescope can be done like that, or only particular company has recommendation about that?
Ma'am, this is universal. So
Yeah.
why we don't recommend to use betadine or Savlon in place of hot water? Because betadine also has chemicals in it.
Okay.
So in the long term, those chemicals will react with the tip of the telescope, and
Oh,
it will cause the degradation of the telescope. So it's always better to use hot water, be it any telescope. Or it's always better to use hot water because it will remove that fogginess or the condensation which happens during the surgery.
yeah. See, this is a condensation of whole shaft of the what do you say? The shaft of the scope,
Telescope.
right? So
Ma'am,
can we dip it
condensation,
15 minutes prior to the surgery in the hot water?
ma'am, that also you can do, not an issue.
Hmm.
But intermittently in the surgery as well, ma'am,
Yeah, yeah,
because
that usually we
yeah,
do, but before starting and
yeah, you can.
just before starting, I think you should take in
Yes, yes,
on the table rather than keeping the on table for a long time. On
definitely.
your trolley, not on table. I'm telling on the trolley.
Yes, yes, yes,
That
definitely. Definitely.
okay.
Rishabh, it was a wonderful talk. Uh,
Thank you. Thank
yeah,
you.
while sometimes a blood stain will be there at the tip of the camera. So if the dry blood stain on the tip of the camera, that then what do you advise for that?
Sir, if there is a blood stain, then we can dip it in hot water in between the surgery. Plus, we can use a dry gauze piece as well. Means after inserting it in hot water for few seconds. So inserting it in hot water for 5 to 4 seconds is the limit. To means in between the surgery, you should do it for 4 to 5 seconds, and then you can remove it and then wipe it with the dry gauze. It will get removed. Not an issue, sir.
See, all the
And the
scope can
routine,
be autoclaved.
Sorry, ma'am.
Autoclavability of the scopes.
Yes, ma'am.
How many times you can autoclave?
I mean, there is no limit, but you should have proper packing and that box, autoclavable box with you. Our
Okay.
our our telescopes are all autoclavable.
Okay. Fine.
Yes.
Yeah, sorry,
What is the
Ravikant.
ideal mode of sterilization that you would recommend for the scopes?
Ma'am, you can do ETO, autoclave is also possible. Plus, let's say if you don't have much of a time, you can dip it in Sidex as well. So, but ETO is recommended. Yeah.
yeah, routinely we use Clara mode. When do you recommend other modes? What kind of procedures?
Sir, so there is a plain Clara, there is a standard mode. So, standard mode will have light will only be in the center and not at the peripheries. Whereas Clara mode is which will provide you a much more homogeneous illumination. And chroma is contrast enhancement mode. So all the blood vessels will be brightly visible. So Clara mode we recommend if there is a smaller cavity cases like ENT or neuro cases. So we recommend Clara to them. But for lab cases, lab gynae or endourology cases, we recommend Clara plus chroma. But at the end of the day, sir, it depends on the surgeon whether he likes chroma that much or not.
Yeah.
Thank you.
Thank you, Mr. Rishabh, for the extensive information about the scopes and the lens. Moving forward, I would like to invite Dr. Ravikant Gowda, sir, to chair the next session on endogynocare case files by Dr. Vaibhav. Dr. Ravikant Gowda, sir, is a member of Mangalore Society and is a very renowned laparoscopic and a pelvic surgeon with more than 5,000 surgeries to his credit. He is the past endoscopic committee chairman of Kasoga. We welcome you, Ravikant, sir. Over to you.
Thank you, madam. Thank you. Yeah, good evening to all. First of all, I would like to congratulate the new team, Dr. Prabha Desai led, Dr. Priscilla madam, and the Asrenda sir, and all the new members of the endoscopy committee who are actively participating in this and actively going to perform major activities. And today we had a little bit theory about the artificial intelligence and the camera system. Now let us dive into what are the actual case scenarios where it can be useful. So many a time theory will be useful to understand, but in real life, how the each and every complicated cases in real life situation. So that we are going to discuss further, which is going to be much more useful. And I request most of the members, most of the audience to clear their doubts and make it a more interactive. Uh, Over to Dr. Vaibhav Manjrekar, sir.
Good evening, everyone. Thank you, Dr. Ravikant, for the introduction. And I thank Dr. Prabha Desai, ma'am, and all the committee members of Kasoga Endoscopy Committee for giving me this opportunity. Is the screen visible?
Yes, yes.
Yes, it is visible.
So this will be the first webinar series, and I'll be presenting my talk on endogyne case 5, obstetrics and gynec society, and Manjrekar Hospital, where I work as the consultant gynecologist and endoscopic surgeon. I'll be presenting a case of laparoscopic hysterectomy in a case of uniconnuate uterus with a non-communicating horn. I'll be discussing about how the patient presented to us, how we went about with the diagnosis and the differentials in this case, and what were the imaging findings and how we approached the case laparoscopically. So a 42-year-old female presented to us with complaints of severe dysmenorrhea. She had 3 previous normal deliveries. Her visual analog pain scale was around 9/10, and she had no relief with oral or injectable analgesics or antispasmodics. She had these complaints since the last 2 years, and they were increasing in frequency and severity. She also had complaints of heavy menstrual bleeding since the last 6 months, which was not responding to any medical line of management. On examination, her general examination and vitals were stable. Her systemic examination was uneventful. On per abdomen examination, her abdomen was soft and she had tenderness over the right iliac fossa. Per speculum examination, cervix and vagina were healthy. On a PV examination, the uterus was around 8 weeks size. It was deviated to the left, and a tender 5 into 5 centimeter mass was felt in the right fornix. This mass was not separate from the uterus, and the mobility was with the uterus itself. We sent her for an imaging, and on transvaginal ultrasound, the uterus was seen to have a right-sided outpouching, which was measuring around 3.8 into 3.2 centimeters. It had an endometrial cavity, but had no obvious connection with the cervix. The main uterine cavity showed continuity with the cervical canal. Endometrial thickness was around 9.1 mm, and there was no cleft between the two masses or the two cavities which were seen. Homogeneous myometrial echoes were seen in the other parts, and there was no fibroid associated. The cervix was normal. The right ovary was slightly enlarged, and a thick-walled cyst of 2.6 into 2.4 centimeters was present, which was suggestive of an endometrioma. It had low-level internal echoes within it. So a diagnosis of a Mullerian anomaly, possibly a uniconnuate uterus with a non-communicating horn, was made. The differentials in this case would have been a broad ligament or subserous fibroid with degeneration, or an accessory cavitated uterine mass or an actin. To confirm the diagnosis, we sent her for an MRI. MRI showed findings which were consistent with that of the ultrasound. The wall of the lesion showed signal intensity, which was similar to the myometrium on all sequences. There was a central cystic component, which had signal intensity consistent with endometrium and blood degradation products. The important point, since we were considering a Mullerian anomaly in this case, was to look at the renal system, and both kidneys were seen to be in normal position. Both the ureters showed normal caliber and course. The right ovary showed a small endometrioma and left ovary was normal. So the diagnosis of uniconnuate uterus was confirmed via MRI. Her routine blood parameters and serology was within normal limits. Pre-operative workup for surgery was unremarkable. After counseling with the patient and discussing her treatment options, we decided on a plan of a total laparoscopic hysterectomy with salpingectomies and right oophorectomy if needed, and the removal of the horn along with this specimen. So coming to the major part, since we were discussing endoscopic surgeries and we have had a session on the different camera options available to us, I would like to go a little in detail to the approach to surgery. So whenever we plan a laparoscopic surgery, and this thing could apply to all the surgeries, in this particular case, we went in for a general anesthesia. It is better to opt for a general anesthesia as compared to a regional anesthesia. Sometimes, since some of us do freelancing surgeries, we have to go to tier 2, tier 3 cities to the periphery where possibility of a general anesthesia may not be there. And then we might have to work on spinal anesthesia. But wherever possible, I think general anesthesia is the preferable mode of anesthesia. Position of modified Lloyd-Davis was given. In this case, we used a vaginal manipulator, the common V-type manipulator which is used. A hysteroscopic evaluation was done to confirm the diagnosis of a Mullerian anomaly. Since I'm an ipsilateral surgeon, I prefer the standard ipsilateral port placement with a 10 mm primary supraumbilical port, 2 ports on the left side and 1 on the right side. The hysteroscopy findings, we introduced a 2.9 mm scope by vaginoscopic method. The cervical canal was normal, endometrial cavity was deviated to the left, and only the left-sided ostia could be seen. Unfortunately, we were not able to retrieve the video of this hysteroscopic evaluation, but the findings were, as I have mentioned above. These were the laparoscopic findings that we could see on initial evaluation. We can see the uterus, the left-sided tube and ovary attached to it. And the right side tube and ovary are seen arising from a mass which is arising from the right lateral wall of the uterus, possibly a non-communicating horn, and which was confirmed by a hysteroscopic evaluation as well. This is another image which shows that the tube and ovary are arising not from the main uterus, but from the non-communicating horn. Whereas you can see in the lower part of the frame, both the uterosacral ligaments are attaching to the body of the uterus. So with this, I begin the surgery. So we started by following the principle of tackling this uninvolved side first. So in any case wherein a pathology is located on one particular side, we always prefer to begin the surgery by tackling the side which is not involved. That lets us have early on control of the vessels and avoids any incidental early bleeding and any impediment to the case which might occur early on. After tackling the left corner by the standard approach of taking the uterovarian ligament, then the mesosalpingeal veins and the round ligament, we proceeded to the right side, to the side of the horn. In this, on this side, we prefer to go via the retroperitoneal approach rather than diving directly to the pathology. We divide the round ligament and then try to expose the iliac vessels by dividing the peritoneum between the round ligament and the infundibulopelvic ligament. The whole idea was to locate the ureter and keep it away and safe from the field of surgery, and to gain vascular control over the uterine, because the course of the uterine artery in this case could have been slightly aberrant as compared to in a normal uterus. So here is when we are tracing the iliac tree. We have developed the iliac tree and the uterine artery. You can see it bifurcating from the iliac tree at its origin. And I'm using a laparoscopic shearer in my right hand, and the left hand is keeping the ureter safe. Once we had located the uterine artery, it was easier to gain vascular control over this side. And then we could proceed with the normal steps of any laparoscopic hysterectomy. So that is us ligating the uterine artery at its origin on the right side. Once this was done and the position of the ureter was confirmed, we moved ahead to divide the uterovarian ligament and separate the right-sided adnexa from the non-communicating horn. The presence of, you can see some presence of endometriotic jelly, and there was an endometriotic cyst in the right ovary. So once again, we were just confirming the position of the ureter, making sure that it was nowhere near where we were dividing the adnexa from the non-communicating horn. And the peristalsis was confirmed, and we proceeded with the surgery. Yeah, that is separating the, once the adnexa was separated, we moved on to the bladder dissection. So the UV fold was divided and the bladder was dissected caudally using strokes of the shearer. Both sharp and blunt dissection is usually used. Once the bladder is down, it keeps the ureters away. The posterior leaf of the broad ligament was also dissected. That is the bladder being pushed down. We try to remain between the two layers of the pubocervical fascia, preventing any injury to the veins which lie deeper to the layer of the pubocervical fascia. And this shows the right-sided uterine artery, which we were able to ligate at the level of the isthmus. Rest of the steps proceeded like a standard laparoscopic hysterectomy. Only on the right side, the uterine artery was having elongated course starting from the lateral pelvic wall, going all around the non-communicating horn, which has been lifted up by me this side, and then ascending onto the isthmus of the uterus. So since we had already ligated it at the origin, since we had already ligated at the origin, we went ahead and divided it at the isthmus. And later on, we proceed to take both the uterosacral ligaments and opening of the wall. In these cases, traction is very important, especially when we are taking the uterine arteries and also when we are opening the wall. Some of the surgeons prefer to use a vaginal tube, but I prefer not to use one, and just by looking at the anatomical landmarks, we go ahead and open the vault. But the important point is always to maintain traction so that the ureters tend to fall away from the field of surgery. This is separating the vault anteriorly, making sure that the bladder is dissected down. That was the specimen having a proper uterus and then this non-communicating horn. The specimen was delivered vaginally. Since she was a multiparous lady, the specimen could be delivered easily, but in some cases, such kind of specimen can cause difficulty, and tissue retrieval, specimen retrieval techniques need to be used, such as lateral coring, vaginal coring, and all. The right-sided endometrioma, since we had discussed with the patient, she did not want to retain that ovary. We went ahead and did an oophorectomy for her as well. After removing that specimen, the vault was closed with 10 vicryl with continuous sutures. Always while closing the vault, we make sure to suspend it to the uterosacral ligaments to provide that extra support and prevent any chances of a vault prolapse later on in life. Even the pubocervical fascia, wherever possible, was taken and incorporated into the vault suture to give it an additional layer of support. The whole idea is that the first suture should involve the angle of the vault, and it should stay medial to the uterine stump. Early on in our career, we sometimes can make the mistake of trying to be overzealous. When there is a bleeding at the angle, we tend to go lateral to the uterines, and that is when there is a possibility that the ureters can get involved in this particular sutures. Make sure that the bladder is dissected well down, and we close this in a continuous manner. Both the uterosacral ligaments were attached to the vault. We give a thorough lavage, and that would be the end of the surgery. We are all well aware about the classifications of Mullerian anomalies. I do not want to go into the details of this, but the most commonly followed is the Eschere one, which describes the uterus from U0 to U6, depending on the different levels of development which takes place. Similarly, the cervix and vagina can also be described. This was the older classification which was followed, but I think nowadays what we prefer is the Eschere one. Few tips and tricks for approaching these kind of cases, and I think this is the important points that we need to discuss. Like I mentioned, we always start and tackle the uninvolved side first when we are going for a hysterectomy. In case we are going for a conservative surgery, wherein we plan to retain the uterus, then always start from the uninvolved side. Make sure we dissect and locate the vital structures early on in the surgery. That involves the ureters, the rectum, the iliac tree, the vessels. Develop relevant planes and avascular spaces, the pararectal planes, the paravesical planes. These are important when we are delineating the ureters, when we are delineating the uterine artery at its origin. Always try to go retroperitoneal when the anatomy is distorted. It gives us easy control over the ureters, allows us to trace the pores. Mullerian anomalies are usually associated sometimes with duplicated ureters, with ectopic kidneys, with horseshoe kidneys. So all these things can be better identified, better delineated in a retroperitoneal approach. It gives us early on vascular control in the surgery. Rectum and bowel, if involved, can be tackled. And in cases of endometriosis, nerves can also be spared in a retroperitoneal approach. Like I also mentioned, we should be well versed in specimen retrieval techniques in case of large uteri, or where there is an oddly located mass, and suppose the patient is nulliparous, or if she has undergone previous C-sections, the introitus may not be lax and may not allow delivery of the specimen easily. And a few pointers I would like to mention for freelancing surgeons, or these can also work for people who are starting their journey in laparoscopy. you're always out of your comfort zone. You're never in your own OT. The table is different, the lights are different, the systems that you carry may not be the ones which are there in your OT. A few pointers for you is try to obtain reports, images, films prior to surgery. Whenever in doubt, whenever you feel that the case is something not from the usual, then try to obtain the MRI pictures, try to go through them. Nowadays, it's easily done over WhatsApp and other sharing platforms. Always carry a hysteroscope. Don't go considering that I'm going for a lap hysterectomy. I don't need to carry a hysteroscope. We never know what might be the case, and it is always better that it is there. It's a useful tool for evaluation. Also helps you to do a cystoscopy in case you're suspecting any bladder injury and ureteric injury. The same 2.9 mm hysteroscope can also be used to evaluate the bladder, and sometimes in skilled hands, even a stenting can be possible. Coming to camera systems, like it's been said over and over again, 3D is the dream, but for most of us, it may not be feasible. It may not be feasible to use one for freelancing in Tier 2, Tier 3 cities. So what can we do as an alternative? A good full HD camera system, I think, should be the bare minimum must when you're planning to do advanced gynec surgeries. Make sure you have a compatible monitor with that camera system. Many of us, we try to use our desktop monitors, Dell monitors, something which is a CCTV monitor, whatever is available in that place of surgery. Please don't do that. Have a compatible monitor. A medical grade monitor is preferable, but if not, then whatever is equivalent to a full HD camera system, please try and invest in that and carry it along. Have a backup if possible. A backup camera system maybe of a lower resolution can be there, but you never know when your camera system can give you problems. So always carry a backup and carry the relevant safety devices like a stabilizer, spares, fuses, etc. to make sure that any power fluctuations do not affect your camera systems. Important notice to the person who's showing camera is always maintain a clean vision throughout the surgery. We have heard from Mr. Rishabh the different ways in which we can keep the tip of the scope clean and maintain a clean vision. But never operate in a field which is foggy, never operate in a field where there is a lot of smoke from the cautery, try to evacuate the smoke. Never operate in a field where there's a lot of blood or you feel there is shadowing because of the blood. Make sure there is good amount of suction. Clean the field. I preferably do not prefer to irrigate the field in a case where there is bleeding, but you can use an RO gauze for just wiping that place and locating the bleeder. And once that is done, then later you can go ahead and irrigate and suction the field. And the most important point, do not hesitate to call for help. A lot of our seniors are available in and around us. They have a lot of experience and I think none of them will refuse a call from juniors like us whenever we are in trouble. And we should make use of their expertise like we are today doing on this platform. I thank Dr. Prabha Desai ma'am and the Kasoga Endoscopy Committee, also Dr. Asrana sir from Kasoga, the president of Kasoga. I thank you for allowing and giving me this opportunity to share a case with all of you. Thank you.
Thank you, Vaibhav. It was an excellent presentation.
Thank you, ma'am.
Anybody has a
Yes,
question?
thank you. Yes, thank you, Dr. Vaibhav, once again. It was very clear in the presentation, especially for the beginners. So when they want to do retroperitoneal dissection,
Yes, sir.
most important thing is identifying the uterine artery at the origin. So what are the points which shows that before coagulating a uterine artery at the origin?
Sir, once we enter into the retroperitoneal plane, the first structure that we encounter usually would be the ureter. Mostly it would be on the medial leaf of the broad ligament if we are using the oncological approach, the one which I described in the video. So that is when we divide it lateral to the infundibulopelvic ligament. The first structure on the medial side, what we encounter would be the ureter. Once we have located the ureter, lateral to it would lie the iliac tree. We start developing the iliac tree, and between the ureter and the iliac tree would be the middle pararectal space. The lateral pararectal space. We develop the lateral pararectal space, and the only structure which would cross this space would be the uterine artery. And the space which lies ahead to the uterine artery would be the paravesical space. These two are avascular spaces. Chances of us injuring any other structure in that space are quite less, especially for a beginner. And the important point is to stay parallel to the direction of the iliac artery and the uterine artery. So whenever we locate the iliacs, try and stay parallel between the ureter and the iliacs. Once you encounter a structure which is crossing it, slightly change your direction, try to go parallel to the uterine artery. One point of importance is just below the uterine artery lies the uterine vein. And we have to be careful when we are trying to separate the uterine artery, especially if we are using a ligature. If we want to put a stitch, then when we are passing the Maryland or a needle holder, we need to be careful that the uterine vein below that is not injured.
Yes, thank you. Thank you. And just one more point I just wanted to add to that is that 3 points we should keep in our mind. One is first medial vessel, which is crossing the ureter, and third point is uterine artery little tortuous when compared to other vessels, and keep it under vision. We should do it like sometimes while violating, we may go very close to ureter. So
we can also
safeguard the
guard.
ureter when
Yeah. Yes, sir. And we can also guard the ureter with a grasper or anything. Just draw it a little more medially. It gives us another millimeter or two of extra space. And I think short bursts of energy would be preferable when we are using an energy device to ligate the uterine artery.
Vaibhav sir,
and
I
many
have
of
a
the big
question for you.
Yes,
yeah,
yes, ma'am.
go ahead, madam.
Sir, while using an energy source on the right side, when you're operating from the left, do you prefer to put your instrument from the right port or the left ipsilateral port?
I prefer to use the right port. It allows me to place the instrument at right angles to the vessel, and that has been the traditional teaching, whether be it in open surgery or in laparoscopy, that whenever ligating or clamping the uterine artery, preferably do it at right angle at the level of isthmus and beyond. Also, I think it gives us a good chunk of the vessel, the length of the vessel, which can be coagulated. When doing it from the left side, I think the instrument is positioned diagonally. Skilled surgeons do it, but then going by the general application of it, I think it is better we do it from the contralateral port.
Yes, so the purpose of inserting a right port is basically one traction if needed, and also to use the energy source from the right side.
Yes, and it also allows for retraction of the bowel or retraction of the bladder or any other assistance that you might need from your assistant.
Sir, and what is your experience of using an anti-fogging solution?
Frankly speaking, I use warm water and betadine, though in the last session, betadine has been, they have advised us against it, but then I think commonly that is what all of us use.
Yeah, it's
Yes,
a
sir.
fogging, anti-fogging, I think in before starting the case we can use, but in between the case we cannot use the anti-fogging solution.
Yes.
The main reason for fogging is CO2 is a very cold gas. Okay.
Yeah.
So if you give a continuous leak and there is a continuous firing of CO2, pumping CO2, then it will be fogging will be there. So either you can use a plain saline or a warm CO2, like a thermoplater. Many Indian company also has a temperature regulator for the CO2, and they deliver CO2 as a 37 degree. Then the fogging will be less.
Okay. Any questions to all other speakers?
Yeah, all other participants, please unmute yourself and ask your questions or put it in chat box if any doubts are there.
Vaibhav, you
Nitin,
figured
Nitin
out.
sir, what is? Yeah,
Sorry,
yeah,
sir.
ma'am,
Yeah,
please
tell
go.
me.
No, Vaibhav, if you would have wanted to preserve this uterus, then how would you have gone ahead?
Madam, the steps would have been, I think, the initial steps would have been similar, wherein we locate the ureter on the right side and locate the uterine artery. Once we have done that, then we proceed to start dividing the horn and then take it out. So any vascular
Suturing
communication
of
which
the
is
lateral
there
wall
to,
of the uterus.
yes,
Yeah.
ma'am.
See, actually, it is very funny. She presented very late with a non-communicating horn with a dysmenorrhea.
Yes,
Right?
ma'am.
After multiparous, it was little tricky in your
Yeah.
case.
That is why initially we felt it was a fibroid
Yeah.
to begin with, but then all imaging modalities showed that there was a cavity and there was
Yeah,
no
only
communication to the
differentiating
cervix.
between acum and this is she was having only one tubal ostia open on histoscopy.
Yes, ma'am. And the tube and
Yeah.
ovary was to the
Yeah,
non-communicating horn.
non-communicating
Then in
horn.
acum, it should have been to the main uterine
Main
body.
horn. Yeah, yeah. That's why. So it was very late. That's why. And she was just 38 years old, no?
She was 42.
42. Okay, okay. Fine, fine.
And
Sorry,
mainly
Priscilla,
this.
you wanted to ask some question, right?
Ma'am, I had a question for Nitin sir. So, what has your experience being using ICG in your 3D scope? Do you regularly
ICG,
use
I'm
it
not
for?
using routinely because I don't do much of the onco work. But nowadays, the application of ICG is increasing in day-to-day practice for the sentinel node biopsy. If you suspect that if it is going to be a non-operable case, then you do a sentinel node biopsy, and then you decide whether to proceed with the radical or you can abandon the procedure. Also, nowadays, ICG or that filter is used more to see the vascularity of the ureter, bowel anastomosis. So, for that application, also people have started using it.
Yes.
And
So
even while
mainly
using the
for
ICG also, after some time it start dissipating.
yeah.
Yes.
So mainly its
Even that.
uses is CA endometrium. Till now, wherever I've seen its maximum uses is in CA endometrium only for selective lymph node
Sentinel.
dissections rather than we used to take a whole pelvic lymph nodes, no, previously. So with the advantage of ICG, sir, even Puttabekar sir always previously he used to take when he used to go to his clinic for means in the hospital, he used to take full like a radical hysterectomy, whole lymph nodes, pelvic lymph nodes. But nowadays he has shifted to because of ICG, only those which are ICG positive lymph nodes only he is taking out, not the whole pelvic lymph nodes.
Yes,
In case of C endometrium. So that is one means less morbidity to the patients. That is one advantage of ICG.
For
Dr. Nitin,
ICG,
that
require a different kind of light source. It's called a D light. So that system is entirely different. The scope is different. The camera is different.
Yeah, yeah.
Okay, if somebody push ICG with a normal telescope, you are not able to see that. You require a specific light source, specific telescope, and a specific module. So the entire system is different. That should be the take-home message. Otherwise, sometimes it will be a problem. Like same thing, people
Yeah,
ask me, my generator has a bipolar. Can I use saline? No, you
yeah,
require
yeah.
bipolar saline TUR. That's a different story. That is a different electrosurgical unit altogether. The same there
Yeah,
also
yeah.
the entire system changes.
Yeah, this is very common. So next time, that's why we are going with the electrocautery as our next
Yes,
webinar.
next webinar.
Because this, I also face whenever I go outside with some, I mean, sometimes I go, but not when we ask for bipolar cutting, underwater cutting for hysteroscope, they say that, yeah, I'm having everything, but it was
Yes.
not there. So they think bipolar has work for underwater cutting also.
Yes. It's a
Yeah.
very good initiative, Prabha. You have started this
Yeah.
webinar series. I'm happy.
Thank you, Dr. Nitin,
And
for support. He is
choosing such
always
a
like a he,
choosing very specific topic is very important. Today's
yeah,
topic was
yeah,
an odd man out, but it's a very practical topic, I will say, because people doesn't know the compatibility between the monitor and a camera. When we used to
yeah.
use Telecam
Even
DX,
and they used to do HD monitor, and the vision is not good. So the compatibility between the monitor camera is very, very important to understand. Initially, we had this telecam, this image one has a CCD technology. The chip which require for CD technology is costly. Now everybody is shifting to CMOS technology, and hence
Yes.
the clarity is not as compared to image one hub. So this all thing is very, very important if you really go into the depth study of the camera system.
And
So I
even
think
light
your
source
topic,
should be also compatible, light cable also
yes,
should be compatible. For HD is
yes.
different. And for our the three whatever 4K and all,
I
light
have seen people
cables
doing
also
white
need.
balance every time. White balance people do every time. So it's not required unless
Yeah.
until there is a change in light cable, light source, telescope, or any one thing you change. Only then, white balance is important. I don't do white balance anytime because my entire system is same. So you don't need to do every now and then, white balance.
No,
So
that
there's some
previously.
practical tips. Uh,
Do you
yes,
remember initial days of what camera we used to get, that single chip or three? That time we used to
yes,
do
for all the
white
cases.
balance
Yes,
for all
not
cases,
required.
but now not with
Not
this
required.
three CMOS or 4K cameras. It's not needed.
Yes.
But company is recommending every time you start the case, do white balance.
No, sir, we
No, sir,
don't
but that
do.
is not required because they don't know. They have been like, set SOP, ha, ye sikha ke aa jana. But to be
Mhm.
practically, if any of the component is not changed, right from telescope, light cable to light source, you don't require to do white balance. You try in your system, sir, you will realize that is not required.
But little bit change in the color will happen once we
That
do
time
the
you
No,
white
do,
sir,
sir.
not
balance.
happen. It will not happen unless until you change the telescope or a cable or a light source. It will
No,
not
or
happen. I'm using
some
since 8 years
buttons
now.
or programs, if you change
Yeah.
also, sometimes it
Then
may
also, then you
happen.
have to do it. Then you
Then
have
you
to
have
do.
to do.
Accidentally, if you press some button, then you might have to do. Otherwise, it
So
will not require.
hardly in means daily 4-5 cases. In that also hardly in 1 or 2 months we sometimes have to touch the white balance button.
And Dr. Nitin,
Anything,
now
Dr.
again about it was interesting to see the artificial intelligence talk. Uh, how much you are using in your practice of this artificial intelligence?
Sir, artificial intelligence, actually, I did a course. I am not applied to the surgical right now, but I am using it a lot of meta and AI to get the information.
Mhm.
That is one thing we should. I am planning one CME in Mumbai, basically, AI, maybe November, application of AI in OBGY and Onco. So let's hope it works out. If it works out, I may plan a hybrid so you all can join. So that is in my mind because recently we did a webinar on cyber crime, cyber security, because that is a very
It
in thing.
was.
Many people are losing money on online scam. So I am focusing on a different aspect, not on a routine OBGY this year as a president, because I want to take all burning issues first, and give a lot of insight in this thing. So I'm working on the AI CME also. So let's see how things goes up.
Meta is being used for the procedures also.
No, any
Meta
procedure
loops.
or anything, any information you want, start using AI, and you should require a specific prompts to get a better response. So this is how you use your AI, Chat GPT. A lot of AI is coming up with a lot of inputs. So one should really know how to utilize this in the day-to-day practice because all patients are becoming smarter than us nowadays. They come with a lot of information. So we should be ahead of them, answering them in some a different way. So they should feel, yeah, doctor is updated. So we
And
should
so
make
many
Google our friend.
guidelines.
Yes, we should make Google and
There's
Meta our friend before our
so many
patient make
guidelines are
themselves.
coming,
Within
and we can
within
understand them in a much easier and
Yes,
specific way by the use of
yes.
this artificial intelligence with less time.
Yes, yes. But
Mhm.
within, after listening to Dr. Nitin says that crime, what cyber crime and all, sometimes it's really dicey whether to use much of the softwares or we have to be how much it is into our routine practice. Unknowingly we use so many of softwares and so many of the datas we use on the phone, and we doesn't realize it. It was really scary when I heard his, that webinar, workshop on last Sunday only it was. So it was really nice actually. We should all, look beyond our, surgical field also to get more safety concerns about our life, you know. And thank you, everyone. And I request Dr. Priscilla Thomas to end this webinar with a thank you note.
Yeah.
And
I
thank
would
you,
like to
Dr.
thank
Prabha, for
our
this opportunity.
Thank you.
Yeah, I would like to thank our chairperson, Dr. Ravikant Gowda, sir, for sparing your time and also sharing your inputs. I would like to thank our speakers, Dr. Nitin Shah, Dr. Vaibhav, and Mr. Rishabh, for sharing your academic thoughts, giving us more take-home tips, and encouraging us to do more into laparoscopy. I would also like to thank our main inspiration, President of Kasoga, Dr. Durgadas sir, for giving us this opportunity and backing us and supporting us, and all the office bearers of Kasoga. And a big thank you and congratulations for our energetic chairperson of Endoscopy Committee, Dr. Prabha ma'am, for making this happen, starting this new innovative thing to start from the beginning. So a well begun is well run. Thank you, Prabha madam, for this opportunity and for this webinar. We hope to see all the participants to join us for our next webinar, which would be every month on the third Wednesday. Thank you
Yeah.
all. I thank all the participants for sparing your time and joining us into this academic session. Thank you all.
Thank you, sir. Thank you, Dr.
Congratulations,
Prasanna.
Prabha. Excellent,
Thank you,
excellent
sir. Thank
opening.
you. Thank you, sir. Thank you. It's all your blessings.
Yeah.
Thank you, sir, and support. Yeah. Thank you, everyone.
Thank you, ma'am.
Thank you, everyone. Thank you, sir. Thank you, ma'am.
Bye, bye, bye.